There are also changes in coagulation factors in pregnancy. So we consider pregnancy to be an acquired hypercoagulable state. And then there's also diminished fibrinolysis. So simply put, it's easier to make a clot. And then once you have a clot, it's harder for that clot to go away, or it's going to take a little bit longer. The body is doing this protectively in preparation for the birth, because after that placenta comes out, we need to be able to quickly clot off. There's a 0.5 liter a minute going to the placenta, so it's important that we be able to clot off quickly. There's a balance there because we don't want to be so hypercoagulable that we can't easily get blood flow to the baby. So there is a bit of a balance. And the diminished fibrinolysis does return to normal by about an hour postpartum, but that hypercoagulable state does extend a bit into the postpartum period. So while we're certainly wanting women to rest right after birth and regain their strength and recover from labor, it is still important to be up and moving at least a little bit to help prevent clots. This is also the reason that we don't give women birth control with estrogen right after the birth. It's because with them already in a hypercoagulable state, we don't want to increase their risk for clots. So estrogen would only worsen that. And it can also potentially have an impact on breast milk production. So depending on their feeding plans, that would also be another reason. And those changes in coagulation kick in fairly early in pregnancy by about 11 to 15 weeks. All right, on to our last section here on immunology. For host defense mechanisms, we can divide those into immune and non-immune. So let's just think through real quick what all our non-immune defense mechanisms are. So first, skin and mucosa. So they're all serving as a physical barrier, whether that's the vagina, skin, trachea, nose. So mucous membranes would be included in that. And then next up, we have enzymes. So that's primarily in the digestive system. Enzymes can have the ability to lyse offending organisms or pathogens. And then pH and temperature, depending on what part of the body you're in, the pH or temperature can be more conducive for some bacteria or pathogens and less conducive for others. So that can serve as a host defense mechanism. And then various hormones, proteins, and even your genetic makeup can also have an impact on one's immunity. So that's just a really brief overview. So then moving over to immunity, we have two different types of immunity. We've got innate immunity and adaptive immunity. So this is just a brief overview. This isn't specific to pregnancy. So innate immunity doesn't require previous exposure. As long as you've got a working immune system, then you can defend yourself. In contrast, adaptive immunity is highly specific to pathogens. So it's based off of having been exposed to that pathogen before. The immune system learns it, and then the next time it sees it, it's able to mount an immune response to address it. So innate immunity, these are the ones that don't require previous exposure. So natural killer cells are regularly searching throughout the body for something to lyse. So our bodies have a lot of those, and then we also have a lot of granulocytes that attack pathogens by phagocytosis. And then the complement system is divided into two categories, classical and alternative. So classical with antibodies does start to get into acquired immunity where you're addressing specific pathogens a little bit. So we'll address that a little more in a minute. So the alternative complement system then, this is really about autoimmunity. So lysis of cell walls, inflammation, histamines. Anytime you're talking about autoimmune type conditions, that's addressing the alternative complement system. And then lastly, interferons prevent protein production. So for example, a virus might enter a cell and then want to hijack it and use all of the cell's equipment in order to replicate themselves. And an interferon would essentially shut down that cell so that the virus isn't able to use the equipment to replicate itself. And it also shuts down all the nearby cells. I know this is review from microbiology way back when, but just wanted to do a brief overview for everybody again. So how does immunity change in pregnancy? So for innate immunity, total white blood cells are increased. This can pose a challenge sometimes in pregnancy, needing to determine if somebody's total white blood count increase is related to pregnancy itself or if it might be an infection. Another difference is that the response can be dampened, the immune response. So that as a result, that can make a person more susceptible to getting an infection, and it can also make it more challenging to fend it off. The response being dampened also means there may be a little bit less inflammation, fewer autoimmune disorders, and a lower rise for white blood count when there is an infection. Often those who do have autoimmune conditions find that their symptoms are a little bit improved in pregnancy, and this would be why. So there can be some variation amongst autoimmune disorders. So let's just go through a couple of the big ones quick to get a sense of what that looks like. So for those with rheumatoid arthritis, about 75% do experience improvement when they're pregnant. Lupus is really fascinating, actually, for pregnancy physiology, and we're not going to get into the details here, but just know that it tends to depend on whether or not they're having an exacerbation at the time of implantation. And if they are having an exacerbation at that point, then outcomes for both mom and baby tend to be worse in pregnancy. And then if they were doing pretty good at the time of implantation, then their lupus symptoms tend to gradually improve throughout pregnancy. For asthma, there tends to be a pretty even split where about a third of pregnant people will improve, a third will do the same, and a third their symptoms will worsen. So that one's a bit hard to predict. For Hashimoto's, or those with autoimmune thyroiditis, their symptoms also tend to improve in pregnancy. And then it's also worth noting that there tends to be a rebound effect postpartum. So while the immune system is suppressed in pregnancy, and that tends to improve autoimmune disorders in pregnancy, postpartum, when the body's immune system bounces back to being in its pre-pregnant state, that can cause an exacerbation. And that's actually the most common time that people are diagnosed with autoimmune thyroiditis is in the postpartum period. For autoimmune thyroiditis specifically, I think it's worth noting that while there is general symptom improvement, their thyroid, if they're needing like medications like Synthroid, they're likely to need more in pregnancy just because the thyroid needs more support in pregnancy. And having Hashimoto's can lead to poor pregnancy outcomes. So it doesn't disregard that point, but just purely from a symptom management point, it does tend to improve. And antibody counts tend to decrease in pregnancy and then increase again postpartum. Adaptive immunity is about being specific to one pathogen, and it can be considered either active or passive. So for active, this is when the body is prompted to make its own antibodies. This can be done naturally or artificially. So naturally would be you meeting another child who had chickenpox as a kid, and then your body was exposed to it and made its own antibodies. Or it could be that you went and got the varicella vaccination, and then your body saw the vaccine, made its own antibodies. So either way, you're now immune to chickenpox, and that can be accomplished either naturally or artificially, and that's considered active immunity. And then in contrast, passive immunity are when somebody has antibodies that were made by somebody else. So they can either be natural or artificial. Natural passive immunity would be when the mom is passing antibodies down. So in pregnancy, that would be IgG. And then in breastfeeding, those would be IgA antibodies. IgG lasts for about 6 months in newborn systems. So if somebody gives birth and then they decide to formula feed, that baby will continue to have the maternal antibodies in the form of passive immunity for 6 months beyond the birth. Whereas if they're nursing, then they'll have IgA antibodies up until the point when they wean. And then artificial would just mean those antibodies came from another source and then were introduced to the newborn or person. And then adaptive immunity is all going to be mediated by B lymphocytes and T lymphocytes. So let's break down immunoglobulins a little bit. So as a review, you'll remember that the bottom of an antibody is referred to as the heavy chain, and then the light chain, or the two arms up top, have an antigen binding site on each end of them that's specific for the pathogen that they're targeting. Understanding the difference between IgM and IgG antibodies is really important. So IgM antibodies are what are first produced the first time somebody is exposed to a new pathogen. Mounting an IgM response is slower and it's not as effective. But then the second time somebody's exposed to that same pathogen, an IgG response will mount because the IgM, think of M as memory, because the IgM response has already happened. So that first response is IgM, it's a little slower, not as effective, and then that second response will be IgG, and that will kick in fast and strong. So for example, maybe somebody either got the varicella vaccine or they got chickenpox sometime in adulthood. If they were to get chickenpox in pregnancy, that response would be slower and they would probably be sicker than if they got it when they weren't pregnant. In contrast, if they're exposed to varicella when they're pregnant but they've had it before, then their body would immediately build an IgG response, and that would be fast and they wouldn't get sick. And not only that, because IgG is able to cross the placenta over to baby, unlike IgM, it would give baby immediate protection against varicella as well. Understanding the difference between IgG and IgM can also be helpful for labs. So for example, say you had a pregnant person who was working in a daycare and their daycare had a parvovirus outbreak. You could draw that patient's IgG and IgM antibodies for parvo and see if they're mounting an immune response for it. If you see that they have IgG antibodies for parvovirus, then that's really reassuring that they've had it before and they have protection against it right now, and that if they were exposed, their baby would also have protection. In contrast, an IgM response would be potentially concerning for the baby because it would imply that that pregnant person did have an exposure to parvovirus and that they're facing it for the first time and they don't have the ability to send antibodies to their baby for it. If you didn't see any antibodies for IgM or IgG, that would imply that they didn't have an exposure. So then moving on to our other antibody types, IgA antibodies are found in secretions like saliva, tears, sweat, as well as breast milk. So for breast milk especially, it's interesting because antibodies are proteins. And so IgA, if it's traveling through a newborn, it's serving to attach to pathogens as an immune protective response, but it's also broken down by the baby and then consumed as a protein source. And any kind of pathogen looking for an easy protein source in the gut isn't going to want to associate with the antibody. So then it also is helpful in depriving potential pathogens of having a protein source. And then lastly, IgE are antibodies associated with the allergies and inflammation. And IgD, we just don't know very much about them, but I wanted to be inclusive. So those are all your immunoglobulins for this slide. So then how is adaptive immunity different in pregnancy? Well, there's a decrease in IgG. One thought is this may just be due to hemodilution. And then there's also a decrease in T cell function overall. So then what are the implications for this in pregnancy? Pregnant women are more susceptible to viral infections as well as fungal infections. For yeast specifically, having all that extra estrogen on board releases more sugars in the vagina, so that puts people at a higher risk for yeast infections in pregnancy. There's also a decreased response to gram-negative infections, so for example, gonorrhea, and a slower response in general to antigens. With bacteria in general, it is a little bit of a slower response, but it is still a good response. Whereas in contrast with viral infections, like thinking about influenza or chickenpox, they're more likely to develop into pneumonia in a pregnant woman versus a non-pregnant person. So since we're on the topic of immunity, let's go ahead and talk about Rh inheritance. So Rh factor is autosomal recessive. So let's take a look at this Punnett square, and we've got Dad on top as represented as a big D and a little d. So since it's autosomal recessive, that means that he is a positive type. If he had two big Ds, that would also be a positive type. And over here on the left, we have Mom, who is Rh negative, and that's why she's got two little Ds. So then with this combination of parents, it would be a 50-50 chance whether their offspring are Rh negative versus positive. And if Dad's alleles were two big Ds, then it would be an 100% chance that the offspring would have a positive Rh type. So then the only concern here is if mother is negative, but the baby is positive. If mother is positive, then this is just a non-issue. If mother is negative and the baby is negative, then it's also a non-issue, but we don't know the baby's blood type in utero. So if the mother is negative, some will choose to test the father, and if he's also negative, then you have nothing to worry about. And again, there needs to be some confidence there with who the paternity test would show as the father. Or you can just proceed with assuming that there is a possibility that the baby could be positive when the mother is negative. So if the baby is positive, that means that their red blood cells have a substance on it that would function as an antigen, where if the maternal blood came in contact with it, the maternal blood would mount an immune response against the antigen that they see on the blood. So if it's Rh negative, then it means that we've just got a smooth surface there and there's no antigen to potentially create an antibody to attack. So now, since we know that when you first come into contact with something, it takes a little bit longer to mount an immune response and it's not as strong, if a mother comes in contact with her baby's blood, it probably is going to be just fine for that baby, but now she'll have antibodies where if she gets pregnant again, then that kind of IgM to IgG shift will happen faster, and she'll be able to send antibodies that can cross the placenta, go to the fetus, and potentially attack those fetal red blood cells. So the concern is less about this pregnancy and more about any subsequent pregnancies. So then clinically, the approach would be that at the first prenatal visit, you would check her blood type along with seeing if she has made any antibodies to that as well as other types of antibodies that could pose a risk to the fetus. So you're checking that at the first prenatal. And then at that 28-week mark where you're doing gestational diabetes and checking in on hemoglobin, you'd go ahead and also check antibodies again if she is Rh negative. And after drawing her blood, you would give her the RhoGAM shot, which is essentially antibodies. You're giving her antibodies that aren't going to cross over through the placenta, but instead will be in the maternal system, where if for some reason there is mixing, say she gets in a car accident or something and the placenta experiences some form of trauma, and there is some mixing, she has antibodies in her maternal system that will automatically find that little Rh antigen marker on the fetal blood cells and attack it so that the maternal system doesn't have a chance to find it and make antibodies against it. So yes, she's got the antibodies in her system, but she doesn't have a way to make them herself. And it's important at 28 weeks that you're drawing her blood to see if she has made any antibodies before you give her RhoGAM, because after you've given her RhoGAM, then all labs you do are going to say, yes, she does have antibodies. And then what you can do is after the birth, you can use that cord blood to check what baby's blood type is. And then if it's negative, you're done. If it's positive, you can go ahead and give mom one more dose of RhoGAM because there may have been some mixing in the context of the birth, especially with the placenta shearing off, where mom might be in contact with baby's blood. So giving her RhoGAM postpartum will give her body a chance to go ahead and take care of all the fetal cells that might have crossed over so that she doesn't make antibodies for any subsequent pregnancies. So in this image, we've got a little bit of a recap here. So the first two images are for a person who didn't have RhoGAM, and then that final image is a person who did. So in the very first image on the left, that is going to be a mom who's exposed for the first time with a baby. So those three little gray circles are representing fetal blood that ended up mixing with mom's blood, and they have the rhesus antigen on them. And so then the mom is able to make antibodies, anti-Rh antibodies that would be able to attack those blood cells. And that's going to be an IgM response. So those antibodies aren't going to be able to cross the placenta. Plus, if there is mixing, it's usually right around the time of the birth. So she's probably not learning how to make those antibodies until after the birth anyway. But then in the second pregnancy, say this baby's also Rh positive, a little bit of mixing happens, and the mom is able to immediately mount up a strong IgG response, and those antibodies are able to cross the placenta. When you hear stories from a long time ago, like, oh, my great-grandmother, she had one baby, and then she had 6 miscarriages, another 2 babies, and then another 3 miscarriages, probably that was due to her being Rh negative. And those babies that did fine were the babies that were Rh negative. And then if there was a positive baby, that was likely a miscarriage. And then we have the passive immunization on the right, meaning that this mother got RhoGAM. And so you can see that there was mixing. Those little gray fetal cells are there with the Rh antigen on them. And then the RhoGAM shot gave her the little antibodies. So she didn't make those herself. She's not going to know how to make them in the future. But those antibodies see and lyse those red blood cells so that the mom's immune system can't detect them and make antibodies. A quick note on RhoGAM. It's essentially an artificial passive immunity form. So it's an immune globulin. And as we've already talked about, it lyses fetal blood to prevent development of active immunity. So it's a form of passive immunity to prevent active immunity from happening. It is a blood product. So if you've got a patient who is a Jehovah's Witness, they may not feel comfortable with it. And it does contain thimerosal unless you order it thimerosal free. And so some of the moms in your care may not feel comfortable with thimerosal. It's a preservative found in many vaccines. Not all practices will test the father of the baby for their Rh status. So if you have somebody who's on the fence about doing RhoGAM, potentially testing dad would be one way to avoid it, avoid needing RhoGAM. So if they find out dad's also Rh negative, it's a moot point. So if somebody's on the fence, sometimes I'll suggest that. We could say, hey, well, why don't we just test dad first? And if he's negative, then we don't have to worry about it. And if he's positive, then we can reconsider if we do want to do it. So when do we give RhoGAM? We essentially give it any time we think there's a chance that fetal and maternal blood may have mixed. So that could be in the context of trauma, like a car accident or a fall or some kind of interpartner violence incident, placental abruption, and then the birth itself. Some procedures like a CVS or an amniocentesis would also be an indication for giving it. And then we're giving everybody it automatically at 28 weeks, and that should cover them for about 14 weeks. So that'll carry us to the birth. So 1 dose of RhoGAM carries you to 14 weeks. And then you'd give it again within 72 hours postpartum. And at that point, we would know if the baby is positive or negative. So then we would just give it postpartum if the baby was positive. 1 dose of RhoGAM only accounts for a certain amount of fetal blood. So if you think there's been significant mixing, such as in the context of like a bad car accident, you can actually do a test to see how much mixing has occurred, and you can give a higher dose of RhoGAM accordingly. So what's the risk without RhoGAM? So it's worth noting that without RhoGAM, it's not as though there's an 100% chance that antibodies will be developed. It's actually just 15%. So we definitely want to be strong proponents for using it, especially if they think there's a possibility that they're going to want to have more babies. But within the context of informed consent and parents who are concerned around it, I think it's helpful to know the numbers. So 15% of women will become sensitized after the birth of an Rh positive baby. And then that risk reduces to 1.5% if RhoGAM is given. And then the risk, so that's at the birth itself. Whereas if it was just for pregnancy, the risk is 1.5% of women will become sensitized. And that risk goes down to 0.2 to 0.6 if RhoGAM is given. So you can see the majority of those becoming sensitized are coming from mixing taking place at the birth itself rather than pregnancy. So then say you have a mom who's really concerned about the potential risk of RhoGAM to her fetus, which it is really safe, but if they are concerned about that, It's just a 1.5% chance that they might become sensitized in pregnancy. So it may be that they're not willing to do it in pregnancy, but they would be willing to do it postpartum if they find out that their baby is Rh positive after the birth. The research behind RhoGAM is great. So I go in with more of an approach of like, hey, this is what we do at this point in pregnancy because you're Rh negative and why? Do you have any questions? Okay, great. Let's plan to do it today. Rather than presenting it and saying like, do you want to think it over for a couple days? So definitely want to be recommending it. But if women do have concerns, having these numbers can help to do an informed conversation. So what happens if there is sensitization? So if mom builds up an IgG response and mounts a response, then those IgG antibodies are going to cross the placenta and lyse fetal cells. So the result would be erythroblastosis fetalis potentially, or isoimmunization syndrome. And with isoimmunization syndrome, you have a really swollen liver because it's trying to process all those broken down red blood cells. So what other antibodies would we want to be mindful of? So at the first prenatal visit, you're going to do an antibody screen, and we're definitely going to look for the anti-Rh antibodies on that screen. But then there are others we can be aware of as well. So ABO incompatibility is associated with newborn jaundice. That's something that may come forward. And then all these other red blood cell antigens are also ones where you might see antibodies on the screen that you run. There's more than just these, but just assume that you'll need to look it up and double check what kind of antibody it is and if it's concerning or not. So at least for these common ones, I have a couple mnemonics for you. I've never seen any of these actually come up on a screen. None of them are common, but the mnemonic I know is that Cal kills, Duffy dies, and Lewis lives. So Lewis would be fine, and Cal and Duffy would be really concerning. And then I'm not going to get into TORCH in depth, but it's important for you to know which kind of organisms and pathogens are easily transferred across the placenta, and in turn are particularly concerning for the fetus. So toxoplasmosis, moms can get toxoplasmosis from gardening or from handling cat feces, particularly cats who've come into contact with mice or birds, as they commonly carry it. The O in TORCH stands for other and includes a few different infections, including listeriosis, which can come from contaminated foods, such as meats or unpasteurized soft cheeses. Treponema pallidum or syphilis really causes issues for fetuses. Parvovirus or fifth disease, that's the one that's common in daycare workers. And then varicella, which is chickenpox. If mom has already had chickenpox or the vaccine, then it really is no issue for her to be around it when she's pregnant because she will mount a quick IgG response. But if she's never been exposed and hasn't had the vaccine, then it's very important that she not be around it. I think especially about nurses who are pregnant and what they might be asked to care for. This is something that they need to be protective and proactive about for advocating for themselves. And then rubella is the R, or German measles. And we can't give the MMR vaccine in pregnancy, but we will check for mom's immunity at that first prenatal visit to see if she's immune. And if she's not immune, then we can put MMR on our to-do list for postpartum. Anytime you've got somebody coming in thinking about being pregnant, it's important to see if they're up to date on their vaccines because we can't give MMR and we can't give varicella for the vaccines while they are pregnant. But we can give them pre-pregnancy. So that's a really opportune time to make sure that they're ready to go. Rubella can cause blindness and pretty bad rashes fetally. So being proactive is important. So then cytomegalovirus in pregnancy can often just look like a mild flu in women. But for babies, they can have severe mental retardation, blindness, and a host of other symptoms. I actually had a patient not that long ago on her 20-week scan. They identified numerous fetal defects. And so we ended up needing to transfer her out of our care because I was practicing at a birth center. And after her birth, the baby lived for 2 days and they were able to do some extensive testing and traced it back to being a cytomegalovirus infection. So she must have had a CMV infection early in her pregnancy, and didn't know it, and they both tested positive postpartum. And then HSV is herpes, and that's pretty rare in pregnancy. Typically, if that's an issue, it's baby having physical contact with the genital lesion during the birth process. So it can cross the placenta, but it is pretty uncommon. If it does, though, it's pretty severe. All of these are really severe infections. So a quick note on vaccines in pregnancy. Obviously, this isn't your antepartum course, so we are going to circle back to this in a future course. But let's just be mindful about thinking through the physiology behind it for this course. So vaccines with live or attenuated viruses or bacteria are not advised in pregnancy due to the potential risk to the fetus. So one example of that would be the MMR vaccine, whereas inactive viruses are okay. So for example, the influenza vaccine is recommended for pregnant women each year. If women develop influenza, it can be a lot more severe in pregnancy than it would be for non-pregnant women. I know somebody who passed away in pregnancy from influenza. So for myself, I definitely prioritize getting the flu vaccine each year, knowing that I am regularly in contact with pregnant women. And I encourage it in my patients as well, within the context of informed consent. Be mindful that the influenza vaccine can come in a live route. That's the nasal route. So you just want to make sure that when they go to get it, that they're not getting a live influenza vaccine. And then just make sure you're staying current with the CDC for what is and isn't being recommended for pregnant women. So they're your go-to resource and a great resource for vaccines and what we're currently recommending. Okay, final slide here is immunology in the newborn. So IgG crosses the placenta, especially late in pregnancy, which is fabulous. That means that all of the pathogens that mom is regularly being exposed to in her day-to-day life are crossing over to her fetus so that that baby can be born already having antibodies specific to their environment. And I included this picture with the little baby and their sibling as a reminder that we can essentially think of siblings as clean. That baby is essentially vaccinated for everything that sibling is regularly around to their environment. So he's born with a special protection that's unique to his household. And honestly, the bugs that we're not wanting baby to be exposed to are those that are in the hospital and the ones that we're bringing in as healthcare providers. So siblings, in the context of immunity, are essentially a safe place for babies. And then there's IgA in breast milk, especially after that first week when milk is really coming in. And then lastly, intestinal colonization of the newborn at birth happens right away. And vaginal versus cesarean birth, cesarean, they're missing out on all that good flora that they would be exposed to if they're coming through the vagina. And we really don't need to be scrubbing women down for labor. Even if they do end up being exposed a little bit to feces or something like that along the way from mom, all of that is helping to contribute to their intestinal colonization right from the start and helping protect them from pathogens. There's a much lower rate of necrotizing enterocolitis for babies that are born vaginally versus cesarean, and that's because of that exposure as they're coming out. It helps them to colonize their guts and is protective. And then I haven't seen this in practice, but I have read reports of some hospitals that have instituted putting a finger in mom's vagina during cesarean sections and then putting it in baby's mouth right after the birth. Or I've also heard of putting a couple 2x2 gauze into the vagina for a cesarean and then taking it out and then just swiping down baby's forehead, nose, and mouth after the birth as well as a means of helping to introduce good flora. This would be discouraged if they were GBS positive. And then I just wanted to close by reading a short excerpt from Everyday Blessings by Mila and John Kabat-Zinn. This is titled, I Am Mindful. Pregnancy is a natural time to begin or deepen the practice of mindfulness. The increasingly dramatic changes that occur in our bodies and in our very perceptions, thoughts, and emotions invite new degrees of wakefulness, wonder, and appreciation. For some of us, being pregnant may be the first time we experience being fully in our body. The changes in our body are of interest not only to ourselves, but often to people around us. We are constantly reminded of our special state of being by the reactions we get from other people, ranging from warm inquiries to unasked for advice to sudden pats on the belly. The myriad physical and emotional changes we experience give us unique opportunities throughout pregnancy to work intimately with many aspects of mindfulness practice, paying attention to our experience, being fully present, being aware of our expectations, cultivating acceptance, kindness, and compassion, particularly toward ourselves and our baby, experiencing feelings of deep interconnectedness. I really do see this with my pregnant patients. I think they have an openness and a connection with their body that I really don't see in any of the other patients that I take care of. That openness really extends well to health promotion. There may be a woman you've been seeing for a long time who smokes, and you talk about it each year at their annual exam. And then when they become pregnant, they're all of a sudden listening with new ears. And there's that kind of openness and readiness for caring for their body and that connection with their baby in a new way. Same for nutrition. Maybe their diet has been so-so, and now that they're pregnant, they're listening with new ears. They're taking all of the thorough nutrition counseling that you're providing to heart, and they're thinking about how they're going to set up the foundation of health for their families. They have an increased awareness of how they just interact in their day through their body, and that connection with their baby is a really strong influence in how they think about how they want to care for themselves. So I really think that we have a special and a unique opportunity within the context of primary care that our fellow primary care providers don't have. I have so much more openness from my pregnant patients than I do during my annual exams. And it is such a sweet, special blessing to be able to walk alongside people as they make these big changes in their life and experience this bond with their baby for the first time. Thanks for making it through a long lecture, and I hope you guys all have a great week.